With the completion of the Human Genome Project in 2003 came the promise of the provision of more individualized health care. To give us his perspective of how far we have come since 2003, it's a pleasure to welcome to the podium Dr. Wayne Grody. Dr. Grody is a professor of pathology and laboratory medicine, pediatrics and human genetics at UCLA, and he's the director of our Clinical Genomics Center. Dr. Grody.
Thank you, Marty, and I especially want to thank you for inviting me to this conference this year. I really enjoy Las Vegas. I've never stayed in the Wynn before. It's really great. And actually, I can't think of a more appropriate locale to be talking about genetics than Las Vegas because, in a way, both things are built entirely on the law of probabilities. And we often refer, when we're talking among ourselves about genetic risk of our patients to, it's a crapshoot or flip a coin or things like that. And, those are certainly the laws of Mendelian genetics as well. So I thank everyone for staying here through the afternoon. I know there's many other options to do in Las Vegas here. But I hope you'll find this entertaining and give you some food for thought on some issues you may not have considered before, but are very relevant to primary care and will only become more so in the coming years. This is no longer some esoteric field only dealing with ultra-rare disorders. It's definitely affecting some of the major diseases that you guys see, and even you'll pick up the rare ones before we ever get referred. And often it will be you who order these tests and will have the burden of explaining them to the patient. There just aren't enough medical geneticists in the country to handle even the current caseload we've got, let alone what we see coming in the next few years. So as Marty mentioned, I run the Genomics Center at UCLA, which is a somewhat more recent entity. For the past 25 years, I've been the founder and director of our molecular diagnostics laboratories at UCLA, and we were one of the first to kind of get into this field. I've always considered that I've spent a large part of my career then in the field of molecular medicine, which I've kind of defined as doing a DNA test for usually one gene, one disease at a time, like cystic fibrosis or sickle cell disease or Fragile X syndrome. But in the last 5 or 6 years, as I'll be showing you, we suddenly have had the advent of a new form of DNA sequencing technology that's orders of magnitude faster than what we had before. And for the first time, it's allowed us to look at actually all the genes in a patient at once, which leads us to the field of genomic medicine. Now, this slide's a little bit incorrect the way it says all genes, all diseases. It is all genes. There's about 23,000 genes in the genome, and we can certainly sequence all of them. But only about a fifth of those actually have a disease associated with them. I think most or all of the others will eventually, and almost every week there's a new one being reported in one of the genetics journals of a disease gene association. But for now, about 80% of the findings we actually don't know exactly what to do with, and that's one of the major challenges in this field. So as Marty mentioned, the Human Genome Project officially wrapped up in 2003. It was launched in 1990. It was supposed to be a 15-year project, but came in 2 years ahead of schedule. And this is a timeline of the project. It's in your handout book. I'm not going to go through every line here. I just wanted to highlight what I've written in orange there, which is that, as I said, it was supposed to be a 15-year project, but it actually got done in 13 years. So the entire human genome sequence of 3.3 billion nucleotides was sequenced, and it cost about $3 billion. That was the budget. So in a way, you could consider that it took 13 years and $3 billion to sequence the first human genome. My lab at UCLA has often been criticized for long turnaround times and high overhead costs, although it's never been quite that bad. But certainly if that was still the state of time and expense to sequence a genome, I wouldn't be giving this talk about clinical genomics. But what's changed has been the technology. So for the whole existence of molecular diagnostics since the early 1980s, our workhorse technique has been a type of DNA sequencing called Sanger sequencing, developed by Ed Sanger in the UK, who actually won 2 Nobel Prizes. One of them was for this. And it's a very robust, good method for sequencing nucleotides of the genetic code, but it's fairly slow. One run of a few days gives you the sequence of about 150 nucleotides. That's just actually a fraction of one gene. And so if we've got 23,000 genes, 3 billion nucleotides, you can see why it took so long to complete the Human Genome Project, which was done entirely with the Sanger technique. Then, like I said, about 5 or 6 years ago, we had the advent of some startup companies, one of them shown here. It's not meant to be an advertisement. In fact, Solexa no longer actually exists as a company, that introduced some new automated DNA sequencers, and they were dubbed next-generation sequencing. I'm showing the ad because you can see they say 1 billion nucleotides at a time instead of 150. The instruments we use currently can do 20 or 30 billion nucleotides in one run of a few days, so you could actually do several people's entire genomes in that time. And that's what's allowed us to actually have genomic sequencing as a clinical test. I have to admit, I never thought it would occur in my career or even in my lifetime, so it's been incredibly exciting to sort of have this paradigm shift in the work that I do every day. I don't want to get too technical for this purpose, just to let you know that the other official name for next-generation sequencing is called massively parallel DNA sequencing. It's massively parallel because instead of honing in on one little region of one gene, like Sanger does, next-gen sequencing takes the entire genome, which the diploid genome is 6.6 billion nucleotides. It busts it up into millions, about 300 million fragments of 100 nucleotides each, and sequences each one of those many times. So that's where the word parallel comes from. Then the computer, which is actually the most important item in this whole field, takes all those billions, even trillions of fragments and reconstructs them back into the full human genome and compares them to the so-called reference genome, which is the product of the Human Genome Project at NIH. So is whole genome sequencing sort of the ultimate personalized medicine? I don't use the term personalized medicine too much because I've felt that every physician practices personalized medicine and has since the age of Hippocrates. We just have some new molecular tools now. But if you were to use this word for any aspect of modern medicine, I suppose genomic medicine is the best example, because what could be more personal than your own genome sequence? Unless you have an identical twin, no one on this planet has the same sequence as you. So it's about as personalized as you can get. Now, this morning we had a great talk about the modern therapies of melanoma, and that's another form of personalized medicine where we have mutation-specific drugs that we give. This is moved ahead fairly well in oncology. It's just now starting to be seen in the area of genetic disease. There are some FDA-approved drugs that only work for certain mutations in cystic fibrosis patients. So you have to sequence their gene to see if they would be candidates. So that, too, is an example of personalized medicine. It's affected my career in a different way. I recently got done with my 2-year term as president of the Specialty Society of Medical Genetics, which is the American College of Medical Genetics. And it happened during my watch that clinical genomic sequencing was launched in a few labs in the country. They actually decided to change the logo and the name of the organization in recognition of this. We've been using this logo since the ACMG was founded in 1991. I don't think anyone ever gave much thought to it. It's not an accurate depiction of anything. It doesn't look like a chromosome, doesn't look like DNA. But they also wanted to add another word to the name. So this is our new logo, which is stylized, but you can see we now have the word genomics in there. Personally, I didn't think this was necessary. I consider genomics a tool of genetics. Genetics is the actual discipline. But frankly, there was some fear among the directors of the ACMG that if we didn't take the word genomics, some other group would grab it. I have not seen that happen yet. I don't see the American College of Physicians adding genomics to their name, or the AAFP adding family physician and genomic physicians. Maybe there's something going on I'm not aware of. But anyway, we've got it for better or worse. It implies that every member of the ACMG is a genomicist, which is a complete lie. Maybe 0.5% of us are. The rest of them wouldn't be able to do anything more with a genome sequence than most of you would if it was handed to you. And I'm not denigrating anyone. None of us understand the genome. It's incredibly complex. So these are the applications of genome-level sequencing that we have now. This talk is focused on what most of our activity has been, which is the use of it for undiagnosed patients who have unusual presentations of common disorders or rare, often unfamiliar disorders to any of us. And I'll show you how that works. Again, based on the talk we had this morning on melanoma, you can sequence tumors. The talk was about mostly the BRAF gene, but people are starting to do broad sequencing on tumors to identify any other so-called druggable targets for the new biologics that we have. For any obstetricians in the audience, you know that next-generation sequencing has completely altered the prenatal diagnosis paradigm. Most women now are not opting for amniocentesis. This technique is so powerful that you can actually sequence the trace amounts of fetal DNA that spill from the placenta into the maternal peripheral blood. And so you just draw a blood sample from the mother's arm. There's no risk to the fetus of sticking the needle in the amniotic sac. And this is really caught on. The ones I have in italics here are just proposed, and I'm going to talk more about some of them toward the end. We could do couple screening for diseases besides just Tay-Sachs and cystic fibrosis. You could screen for all of the thousands of known recessive disorders to see if they are at risk to have an affected child, but nobody's doing that yet. No one, to my knowledge, is using it for prenatal testing, and the ethical concerns I'm going to tell you about, it'll be fairly obvious why we don't want to do that yet. Newborn screening, I didn't think this would be ethical, but there are actually some NIH-funded studies now to see how well this would be accepted by parents. I'm actually thinking that within 10 years, every newborn will probably have their whole genome sequenced. They may not report out the results, but it'll be probably stored in the medical record somewhere, and that's where the electronic record really comes in handy. And then I will talk at the end about doing predictive screening for healthy individuals. The challenge for all of these and the ethical issues are the variability of the genome between all of us. Roughly 1 in every 500 nucleotides is varied between people in this room. It doesn't mean we all have that many mutations. Most of these are called benign polymorphisms. They've just diverged through human evolution. They don't really affect protein function. But if they haven't been studied before and you pick one up in a patient, it can be very hard to tell if it's a benign polymorphism or a novel pathogenic mutation that could cause disease. So every time you do a whole, we actually do whole exome sequencing. The exome is the 230,000 exons or coding regions of genes in the genome. It accounts for only 1% of the total genome. The other 99% we don't know what it's for. But most Mendelian disorders are in the coding regions. Whether or not we find a mutation, in every case we get between 20 and 30,000 variants that don't match the so-called normal human genome at NIH. Now that genome's not normal either. There is no normal genome. We all have mutations, but we have to use some kind of reference baseline. If you do a whole genome sequence, the other 99%, you get 3 million variants that don't match. No one manually can go through all these, so we have to set our computer to filter out the ones that look most likely to be benign. But the computer and we can be very fooled. I'm always worried the computer's throwing out something important, and once that happens, no one will ever see it again because we can't go back and look at all those thousands of variants. Let me give you a little taste of how complex this is, going back to just the days of single gene testing. So you're all familiar with BRCA1 and 2. causing familial breast ovarian cancer. You get pedigrees or family trees that look like this, where there's affected women or sometimes men with male breast cancer in every generation. And the young adult women here whose mother died of one of these diseases would be the ones coming in for the predictive or pre-symptomatic testing to see if they inherited the mutation, which would give them a very high risk of breast cancer, although not 100%. And then they might decide to have prophylactic bilateral mastectomy or whatever. Until about a year and a half ago, all of the sequencing of the BRCA1 and BRCA2 genes was done in one lab in the country. Many of you have probably sent samples to them. This is their building. It's Myriad Genetics in Salt Lake City. The reason is that until June of 2013, they owned the exclusive patent rights to both genes. And there was a Supreme Court case that I was very involved in, working against Myriad for the plaintiffs. And the court decided 9-0, unanimous, which for this court never happens. It's always 5-4. Well, this was 9-0, saying that genes are products of nature and therefore cannot be patented, which was our position. But for most of the existence of these two genes, or at least their knowing about them, which dates from 1994, Myriad did all the testing. Many of us didn't like that, but it had one probably beneficial scientific part of it, which was they had the exclusive database of pretty much all the BRCA mutations and variants in this country. They don't publish it, unfortunately, but I've had friends who work there who've sort of given me personal communications. This slide's already out of date. I think they've done sequence of over 1 million people now for both genes. And they have a database that's proprietary to them of tens of thousands of variants and mutations and unknown polymorphisms that they have cataloged. So if you consider this company's been doing this BRCA testing nonstop, 24 hours a day, since 1994, you would think that they would know these two genes backwards and forwards, and anything there is to see in these genes they've already seen. But that is not the case. Their genetic counselors to this day still confide to me that every week in the course of their normal caseload, they identify between 10 and 20 new missense variants. Those are single nucleotide substitutions that neither they or anyone else has ever seen before. And they actually have a lab meeting of their directors where they go through each one and try to figure out if it's a benign polymorphism or a real mutation that can cause breast cancer. And there's ways to do this. You see if the amino acid at that position is evolutionarily conserved in lower species and things like that, but none of these are absolutely predictive. So this is the challenge with just two genes. You can multiply this times 23,000 for a whole exome sequence, and that's what we're dealing with on every genome level test that we do. Just one other example that hit even more closer to home for me personally is the cystic fibrosis gene. Our group at UCLA was very involved in launching as a national policy that all pregnant couples be offered CF carrier screening, whether or not they have a family history. It's a recessive disease. The carriers don't know they are carriers until they have an affected child. And I ended up chairing a committee of the FACMG that went through all 2,000 known mutations in the CF gene and chose the ones that usually cause serious symptoms and were somewhat more common, not so rare that you would never see them. It ended up to be a panel of 25 mutations, which is the minimum screening panel launched in 2001. But within a few months, we realized something strange, that one of our mutations, I148T, is not a mutation at all. It's a completely benign polymorphism. It had been found in some CF patients, and they had overlooked the real mutation that those patients had. The problem with this is these couples are getting screened to decide whether their fetus may inherit both mutations from the parents, and if so, they might decide to terminate. And I know of at least one case in Los Angeles, I'm sure there were others, where the fetus did have the I148T and one of the other classical mutations like delta F508, and the couple terminated, when really that baby would have just been a healthy carrier of the delta F508, would never have had cystic fibrosis. Needless to say, we quickly removed this one from the panel. But again, it shows you our committee spent probably 3 years carefully vetting all 2,000 mutations in the CF gene, and we still made a mistake. We don't have 3 years to interpret every clinical genome sequence on 23,000 genes. So it's almost an insurmountable problem. Not only that, there's different kinds of unknown and unexpected findings you get when you look at all the genes. The first category here is sort of what I already talked about. You may see a single nucleotide substitution that no one's ever seen before, and you have to figure out, is it benign or pathogenic? Sometimes you can't, and the report just comes back DNA change of uncertain significance. And we call that a VUS, variant of unknown significance. You may find a real mutation, but it's in a gene that has nothing to do with the phenotype, the symptoms of why you ordered the genome test in this particular patient. So the question then is, have you discovered a new disease gene that was never linked to this disease before, or is it just a spurious result of no significance? So I call those GUS, gene of unknown significance. You're always going to pick up all kinds of other things that are real but probably not that relevant to why the test was ordered. You'll get all kinds of carrier states, like, you know, the person's a carrier for CF or PKU or something. It's not going to affect that patient. It has nothing to do with the problem you ordered the test for, which could be autism or something like that. Do you report those out, especially in a child? You know, I don't know, and there's no rules about that. We'll also get various DNA changes or inherited variants that affect pharmacogenetics, how fast or slow you metabolize a drug. You all have heard about the warfarin sensitivity test and so on. Does that really matter to a 2-year-old with autism who's not going to be getting warfarin? Do you report that out? But those are sort of academic questions. The one that I've spent a lot of time the last 2 years debating, and even debating with myself, because I still don't know the right answer, is the last one here. Here you find a real mutation, but it's in an off-target gene. It has nothing to do with why you ordered the test, but it's potentially life-threatening. So an example I like to use is, let's say we have a 3-year-old girl with congenital epilepsy, and the drugs aren't working and so on. So there's nothing on MRI that looks like an anatomic focus of the seizures, so the idea is that it could likely be genetic. So they ordered the whole genome or whole exome sequence. There's about 100 known genes for epilepsy. We make sure we look at those very carefully. If we don't see anything in those, we'll look at all the other 23,000 genes. Let's say, as often happens, we don't find any mutation in any gene that explains the epilepsy, but we do find a real mutation in the BRCA1 gene. What do you do with that? BRCA genes have nothing to do with epilepsy or anything neurologic. We have a very strong ethical rule in genetics that actually was written when I served on this NIH task force on genetic testing in the late 1990s, where we say that predictive genetic testing in children for adult onset diseases should not be done unless there's some intervention you would need to do in childhood to cure it or prevent it. And that certainly is not the case for a BRCA mutation. You're not going to take this 3-year-old girl and subject her to a bilateral mastectomy, let alone remove the ovaries before puberty. All you're going to do is lay on this very worrisome finding, sort of a black cloud, could affect her health insurance, ability to get that, and all kinds of things going forward. And really, the parents probably don't care about that. They're very worried that their child is just seizing nonstop and probably has developmental delay. Do they really care that in 40 years she might get breast cancer? So my initial feeling was not to report such things. But what if she does get cured of the seizures and grows up and dies of breast cancer at age 30 and finds out we had this knowledge and didn't disclose it? Would there be a liability, let alone an ethical, moral issue? What if she got the BRCA mutation from her mother, who's 30 years old now, and really is at risk of breast cancer? Wouldn't we at least benefit her by reporting it out? So these are what are called off-target or incidental findings. It's all the hundreds, thousands of things you get that have nothing to do with why the test was ordered, but now you've seen them, and you can't pretend you didn't see them. You've got to make some decision of what to do with it. So these people at Harvard published in JAMA a while back that all of these thousands of off-target findings are called the incidentalome. And they say here it's a threat to genomic medicine, which I agree with. The price of DNA sequencing, the technology, all that's getting better and better. It's this moral, ethical issue that I don't think will ever go away. And I'd be interested in the discussion section what your feelings are about that. Let me at least put it in context. So are we facing a time that for the first time in laboratory medicine, before you order the clinical lab test, you may need to ask the patient or the parents of the patient if you want to receive all the results or just a portion of them. And how might this be done? You could have a multi-tiered consent form, which I hasten to point out nobody is using. It's felt to be too complicated, but theoretically you could do this. So you could say, or the parents could say, I want all the information you get, everything from the next generation sequencing machine. Now, if they literally want that, the raw data from every genome sequence, each one takes 5 terabytes of memory. So it's not something you're going to hand them on a piece of paper. It won't fit on a DVD. I don't know how you'd give it to them unless maybe a big server that they could pick up in a truck. And even if they take it home, it's just going to be billions of A's, C's, G's, and T's that don't mean anything to anybody. So we try to discourage that. They could say, I want only the relevant information for my or my child's disease. So in the epilepsy example I gave, I would just report the test out as negative. I wouldn't even mention the BRCA finding because it has nothing to do with epilepsy. They could say, I want anything medically actionable for the patient's age. Actionable is sort of a new word that is in this genomic field now. And that people use that to decide whether to report things or not. Again, since BRCA mutations are not actionable in a 3-year-old, I would report the test as negative. They could say, I want anything medically actionable either now or into the future. Okay, now we would report it. Or anything actionable for the relatives, we would. But like I said, no one is doing this kind of consent. It's felt to be too complex. The only guideline, and again, I had to reveal it during my presidential tenure at FACMG, is this one. It was a committee that had weekly conference calls for over a year. I was on the committee, I didn't chair it. And then in our Phoenix meeting, we came out with these guidelines for which diseases, which genes to report, and how to do it if they are found incidentally. I'll tell you right now, and you'll understand it as I go on, that although I'm a co-author on this paper, my own lab has never followed the guideline. And I'll see what you might think if you were a lab director. This is a summary of the paper, and I think you'll see some of the problems here. We started with hundreds of genetic diseases. We whittled it down to a group of 25 diseases and 50 genes. Some diseases have more than one gene, like breast, ovarian cancer. These must be reported mandatorily. In fact, they have to be sought out, even if that's not the reason you did the test, and they must be reported. The same rules apply to parents. We often do trios, mother, child, father. It's more easier to interpret those. This is where it affects you in primary care. We kind of absolved ourselves of the burden of actually explaining this to the patient. It's all just going to be given to you, and you can handle it. And I don't envy you that task. But the most controversial of all is the last one here. The patient cannot opt out of receiving these incidental findings. In other words, if in the pretest counseling they get so scared of possibly revealing a breast cancer gene or a colon cancer gene, their only choice is to not have the genomic test at all. You can't, it's all or nothing. You either get everything we find or you can't have the test. And that seems quite paternalistic, I think, to many people. There was a rash of editorials in all the major journals. I'm just showing one of them here, saying that we've overridden patient autonomy. We've changed what's really a diagnostic test into a screening test, looking for all kinds of unrelated things. I kind of agree with that. But this committee was made of very smart and passionate people, that they're not, dictators. Why would they seem to run roughshod over patient autonomy like that? Well, they used an analogy from another specialty of medicine, which at the time I thought made sense, but then the longer I thought about it after the paper came out, the less I liked it. But see what you think about it. So this is the analogy. This probably means nothing to you right now, but Those who ride bikes know that you may hit a crack in the road and go flying. Let's say that happens to you, and you're not seriously injured, but about a week later, you still have a nagging pain in your side. So you're worried, did you fracture a rib? So you or your doctor, however you want to do it, will order a chest x-ray, and they may find a cracked rib. Most likely they won't. It was just a pulled muscle. But suppose in the course of the x-ray, they don't see the cracked rib, but they do see this, an opacity somewhere in the lung, which could be lung cancer, might be nothing, but it certainly demands further investigation. It's very worrisome. Does the radiologist not report out this opacity simply because the requisition form for the x-ray said rule out rib fracture? This opacity has nothing to do with rib fracture. It would be an incidental finding. But of course, the answer is radiologists have to report everything they see in this field of view, regardless of the indication for the test. If the heart is too big, they report that. And so it was felt that we geneticists are sort of the radiologists of the genome. Just like a radiologist can interpret this better than I can, as a geneticist, I should be able to interpret anything in the genome, which of course is a complete nonsense. I can't. I know the CF gene pretty well, but that's about as far as it goes. But that was the analogy they used. And like I said, the more I thought about it, the less I liked it. Radiology's been around for over 100 years. Billions of people have had chest x-rays. It's well known what you do with a finding like this. You probably would get a CT scan to better define it, maybe a follow-up one in 4 months to see if it got bigger. You could do a needle aspirate. The chain of follow-ups are very well known, whereas it's not so well known in what you do with a genome finding. So like I said, this had to be discussed when I was the president of the ACMG. It was a fairly momentous time. And I felt that if I didn't like the radiology analogy, is there something else I could use? And I haven't actually shown this much beyond that ACMG meeting in Phoenix, but as my friends know, I have a side hobby. I like a lot of movies and television, and I do some technical consulting when there's a genetics plot to either the movie or TV show, and I enjoy that a lot. So I had a little part of my talk titled this. I figured, could I find some movies where the plot depends on incidental findings? And it took months of research. I'm not going to go through all of the ones I found, just show you a couple, to see if it could teach us a lesson. These are somewhat older movies, but some of you will be familiar with them. So this is a movie from 1996 called Blow Up. It was directed by the Italian director Antonioni, but it took place in London during the mod era. And the actor with his back to us, David Hemmings, plays a fashion photographer who is shooting runway models during the week, but on weekends, on his own time, he just likes to go around London and take pictures of scenes that intrigue him. So he was sort of captivated by this romantic couple here in the middle of a park, took some pictures. When he got back to his photo studio and printed them and then enlarged them more and more, hence Blow Up, he saw what looked like a dead body in the background behind a tree, and the rest of the plot is him chasing after that. Just one more. This is from 1981, directed by Brian De Palma, Blow Out. It's a clear homage to Blow Up. This is a young John Travolta who played a sound man for very low-budget, sleazy horror films. And he was out in the woods one night getting ambient sounds of the forest, because that's where a murder was going to take place in the movie, with his tape recorder. And he's recording, it's very quiet, when suddenly he hears a loud popping sound. His attention is drawn to a bridge across a river about a mile away. It sounds like a tire blew out. The car screeches, goes through the railing, into the water. The driver of the car drowns. It turns out the driver was a candidate for U.S. Senate in the upcoming election. Well, when Travolta gets back to his sound studio and plays back his tape, but at slower speed, that popping sound actually differentiates into two separate sounds. There's the pop of the tire blowout, but it's preceded by the crack of a gunshot. So the tire was deliberately blown out. It wasn't an accident, and this was actually an assassination. And the rest of the time, he's going on investigating that. I had a bunch of Hitchcock movies and other things I won't bore you with. I will just say that I noticed a pattern in all of them that was unvarying. In every one of these movies, the protagonist, the hero, does choose to act on the incidental finding. And in every case, what that leads to is either him or someone he loves getting killed. So, so that should be a little humbling to us. Needless to say, I do not follow that mandatory guideline. This is part of our informed consent form for our whole exome sequencing. We have both an opt-in and an opt-out, so there's no question whether the patient wants to receive incidental findings or not. Since someone may ask, I'll tell you now, 98+% of the patients choose to opt in. They do want the incidental findings. I would question, though, whether they really understand what they're asking for. That worries me a little bit. They also have to be warned for some other off-target findings that may come from the exome test. Many of the disorders in genetics will have no treatment, although we find that the parents still like the closure of that. If we do the trio, mother, child, father, we're also doing a paternity test. We may find out the father's not really the father. If we see very long runs of homozygosity, where both chromosome sequences are identical, it means that it was a consanguineous or related mating, like cousins. But if there's really, really long stretches, it means that it could only mean incest, father, daughter, uncle, niece, and of course that has to be reported. And there's many other issues they have to be warned about. Most of the labs with these next-gen sequencers have chosen to only offer gene panels. So each of these families of genetic disorders has 20 to 30 genes, or even 100, and that way you don't go near any off-target findings. So we'll do the 25 genes for hypertrophic cardiomyopathy. If it looks like that's what the patient has, we may or not find a real mutation, but you're not going to stumble on a BRCA mutation because you're not going anywhere near that. We've chosen not to offer the panels because in all cases, about half the patients who really have hypertrophic cardiomyopathy, you don't find the mutation, whereas you may if you start looking for other genes. And this is just one example of one of our lesser yield conditions, developmental delay. Many labs have panels of genes, and the yield you see is not very good. When we do clinical exome sequencing, we get much higher level. Even if you lump all these panels together, it doesn't reach it. And it just means that the panels have all the known genes, but there's many unknown genes that they're not covering yet. You should know that we're on the cusp now of what's called next generation or third generation sequencing. These are some of the companies coming out with platforms. I'm especially excited about this Oxford company. They claim that within a year or two, they're going to have a DNA sequencer that will sequence the entire human genome in 15 minutes for $100. And when that happens, the floodgates are going to open. That's where you guys get involved. It'll be very hard to refuse this. Should this kind of sequencing be offered to healthy people, newborns, I've already talked about, prenatal and so on? We're getting pressure from our own internal medicine department now to offer testing on healthy adults for their future risk for cancers, heart disease, and so on. It's been called wellness screening, which I don't like that term at all. I don't really know how we would do it. Would you look at every gene in the genome with all these unknown variants? Should it be limited to the incidental findings panel of the FACMG, which includes long QT syndrome and malignant hyperthermia? It was what we thought at the time were the most high penetrance actionable genes, but who knows if they are. What I worry about is the phenotype of the patient guides us so much when we do a whole genome interpretation. But if the patient has no phenotype, if they're healthy, all these variants are sort of equal, and I don't know how to weed them through. Will it have an ethical issue that only the wealthy will afford it? Probably, because insurance won't pay for it, I'm sure. Who will explain it? And we have the potential for insurance discrimination or employment discrimination. I'm worried we could be in the world of Gattaca, where people are discriminated for employment based on their newborn genome sequence. Theoretically, we're protected from that, from this legislation that was signed by the President in 2008, the Genetic Information Non-Discrimination Act, which forbids insurance companies from raising your rates or dropping you or an employer firing you because of genetic information. But it has yet to be tested in court. So we deal with a lot of these these questions by our genomic data board, composed of all of our lab personnel, clinical geneticists, trainees. We have dedicated genetic counselors, bioinformatics people who are very key to this, and the ordering clinicians if they're available. And if they're not from UCLA, we can patch them in by a video conference. And it's really turned out to be helpful. I'll just show this one case, because we're running low on time, of how it helped so much to have the clinician there. So this was a teenage girl who had mostly been seen elsewhere, and since age 2 had a diagnosis of juvenile ALS, which can occur. But when the UCLA neurologists looked at her, they didn't feel her movement disorder fit ALS. They didn't know what it was, so they ordered the whole exome. This is just page 1 of one of our results. I try to keep them simple, but it's not that easy. We didn't find anything in the known ALS genes, which are listed in the center of the slide there, but we did find a homozygous stop mutation, very deleterious, in a gene none of us have ever heard of called AAAS, which stands for achalasia, Addisonianism, and alacrima syndrome. It also has ataxia, so it could be 4 A's. That's why it came up. I probably would have thrown this out as not relevant if the pediatric neurologist had not been there, because I asked her, has the patient ever had trouble swallowing? There was nothing in the UCLA chart about that, but she said, oh yeah, before she came here, she had all kinds of esophageal motility studies and all of that, so she really did have achalasia. She had some endocrine problem, and I asked her, does she cry? Alacrima means no tears. She didn't know that, but she went back and checked. Sure enough, no tears. So this explained the problem, but I think if she had not been in a conference room with us, I would not have reported it. So communication with the clinician is absolutely essential. The diagnostic yield is better than I expected. I thought it would be a few percent. If you take the definitely pathologic variants and the likely pathogenic, which are in the red here, we get a yield of about 45%. And this is just a list of some of the many diseases I had never heard of before that we've diagnosed. You can see AAAS, which will probably always be at the top alphabetically. Trio cases are better because we can cancel out thousands of variants that are found in both the healthy parent and the affected child. We don't get much good yield on generic autism and developmental delay. The volume keeps increasing as more people are aware of it. Insurers are more open to coverage than I had expected. I thought their knee-jerk reaction would be that this is investigational. We're not going to pay for it. But once we explained to them that this one test can theoretically stop all the different tests, which together have cost way more than this one test costs, and end their so-called diagnostic odyssey, which we get from Homer, they see the logic of that, and they've been paying for it. And again, since I like movies, I've sort of changed this poster a little bit in that way. I'll skip this next case and just end with what should we do with these off-target findings. I'd be interested in your feelings on that. I don't really know. I go back and forth deciding, are we being too paternalistic to assume the patients would not want these results, which I've tended to do, or to assume they would want them, which others have tended to do. You can tell my bias is not to burden them with unrelated things, but if I do that, am I guilty of being like someone else in another movie I would just cite? And, you know, who are we to say that they can't handle the truth? So I just want to give you appreciation for the promise of this new field, but the tremendous ethical challenge. It's the worst ethical issue I've ever faced in my career, and I've had plenty of them. These incidental findings are nothing to laugh at. They can really be serious and drastically change someone's self-image, as shown here with Kermit. So I will end there. Thanks again.
Questions for Dr. Grody?
So you showed us your consent form for opting in or opting out, and you touched on it, but we're in primary care probably going to be addressing that. And how can we know the patients there's any semblance of informed consent or refusal of consent. Are you and your organization going to be giving us any guidelines or data or continuing to talk about it so we out there will have some idea how to approach it when our patients are asking us to be the ones helping them decide how to fill out that form?
Yeah, that's a great practical question. I can tell you, our genetic counselor who works in our Clinical Genomics Center, she spends at least 1 hour pre-test with every family going over this stuff. You guys obviously don't have the time to do that. So the ACMG does have a committee that's coming up with some teaching materials that could maybe just be handed out. I admit it's a real problem. I'm not sure even after an hour they really understand. I don't think they know an incidental finding until they get hit with one in the face, and then it's too late.
Person with the microphone?
I have an interesting case. I do endocrinology, get some odd referrals. One was a 38-year-old female with premature menopause. All the autoimmune tests were negative. I did some research, and it looks like there is a 5% genetic incidence in premature menopause, Fragile X, and so I'm going to refer this case to your service, and I think that you may want to add premature menopause, even some infertility to those lists that you had. I think is a good future.
Yeah, that's another good disease list. But with it, we do deal a lot with infertility. We like them to at least have done the Fragile X test by itself, because that is a cause of premature ovarian failure. And assuming that's negative, then you can open it up to the genome.
So Myriad comes to our office, and they have all this genetic testing available. Okay, so in primary care, after what you just said about an hour talking in advance, do you think there is a place for us as primary care ordering the, 28 panel thing now? Or just say, you know what, you have risk factors, let me refer you to the genetic specialist.
There's always the option to refer to genetics, and that would be perfectly fine. I don't know if we can handle the volume as this keeps growing. You have ordered Myriad tests, and you're right. Myriad has now gone beyond BRCA1 and 2. They have a bunch of other breast cancer genes. Most of the others are much lower penetrance than BRCA. I have nothing against those kind of panels. It's just if they come up negative and it's still a family with very high suspicion, you may end up looking at the whole genome anyway. I may be stretching it, saying primary care people will be ordering these things left and right, but I think as it becomes more routine, it will fall more on your shoulders. So he's asking how many diseases do we pick up and what's the cost? I'll answer the second one first. We seem to be one of the cheaper ones. Our cost for whole exome sequencing is $4,500. I've heard costs anywhere from $3,000 to $13,000. I don't know why there's such a variance. As far as how many diseases we pick up, there's almost no end to it. Most of them in these children are very rare, and I've never heard of them before. We do get some common ones like Lynch syndrome genes that nobody had happened to check for before. Our total list of diseases, I don't know what, it's probably at 200 or 300 by now. I look at it more as a percentage. Out of all the cases, we get an answer in about half of them. And we're very conservative. We won't report a variant out unless it's been well seen in another gene and at least in in publications in 2 unrelated families.
Your thoughts about these commercial labs like 23andMe who are selling genomic predictions about risk to otherwise healthy people?
Yeah, I've always been very skeptical about direct-to-consumer testing. 23andMe, they're in a bit of a hiatus now because they've been slapped on the wrist by the FDA for not having a healthcare provider in the loop. You just collect saliva at home, mail it in, use a fake name, and then they tell you you've got a BRCA mutation. What are you supposed to do with that? That's why I've really objected to it. Up till now, they've looked just for individual nucleotide changes. They were about to embark on whole exome sequencing when they were stopped by the FDA. I don't want to be overly paternalistic. I mean, it's a free country, but there's a feeling that just since DNA is easily acceptable through spit or something, accessible, that makes it a kind of a form for home entertainment. I mean, no direct-to-consumer company is offering prostate biopsies because you can't do that at home. But is DNA any less serious than a prostate biopsy? I would say it may be more serious, and it's not just a medium for fun, which is the way this stuff is sort of marketed. One last one. Okay, never been asked that publicly. He asked if I've had my own genome tested. I have not even tested my own cystic fibrosis mutations. I made my wife do it when she was pregnant, and since she was negative, I didn't have to worry. I don't want to know anything. I would never do my whole genomic sequence. Never.